Dr. Sandra Ganesh. She'll be enlightening us on the topic of biometry in children. Dr. Sandra is a senior consultant of pediatric ophthalmology and strabismus at Aravind Eye Hospital, Coimbatore. She has 15 years of experience in this field and she has around 30 publications as first author. And she has special interest in complex strabismus, myopia, amblyopia. And thank you. Over to you, ma'am.
Thank you very much, Dr. Shaji, for your kind invitation. And thanks to all the speakers before me who did a wonderful job, and I had a lot of learning here. So I'm going to talk about a different situation as well, which is biometry in children. Modern pediatric cataract surgery involves timely restoration of the visual axis. You should appropriately investigate, ensure a proper general anesthesia, and also age-appropriate post-operative refraction is mandatory. So if you see children like these, you know that you are looking at total cataracts, and we need to operate as soon as possible. We cannot keep waiting until we get a good biometry. But usually up to the age of 1, we do not place an IOL. That is the generally agreed consensus. But we do operate. So for dense bilateral cataracts, the window is around 4 to 6 weeks of age. Before the age of 4 weeks, there is a high risk of aphakic glaucoma, and beyond 6 weeks, it's going to compromise the visual outcome. So initially, we give glasses or contact lenses. And these slides, you look at the partial cataracts, where it is younger or older, we can wait till we get good readings. And the indication for surgery in partial cataract, in verbal children, you are looking at like Snellen's acuity of less than 6, 9, and 8. Whereas in pre-verbal, you base it on the visual behavior of the child. And the surgeon should always decide whether the blur created by the partial cataract justifies eliminating the natural mechanisms of emmetropization and accommodation. So bilateral cataract is around 1 year roughly. Corneal diameter should always be more than 10, and also you should ensure that there is an uneventful surgery with in-the-bag implantation. Minimum age for bilateral, as I said, by around 1 year. Unilateral, you can decide to place an IOL earlier on, provided the other parameters are normal. But why do we think so much about IOL implantation? Because there are possibilities of huge errors in power calculation. The surgery as such is very simple. You can place an IOL. But the problem is in the calculation and the lens power determination. Because most of, like in smaller eyes, the axial length will be less than 20, age less than 36 months, where there is a chance of getting errors. So when that you have decided to operate, what next? So you should be looking at what is the ideal IOL power to be chosen, what is the formula, axial length, K reading, all has to be calculated, and there are a lot of clinical variables also. But what are the challenges when it comes to children? One is the measurements, because in younger children you may not be able to get a measurement in the wake state. You have to rely on measurements under general anesthesia, which may not be entirely accurate. All the formulas are based on adults. So there is no formula which has been developed for children. IOL material, and there's a growing eye. The target refraction is not emmetropic as in adults. We have undercorrecting the child because of otherwise there will be a myopic shift later on. So these are the factors, just to enumerate what are the factors causing inaccuracy in pediatric IOL power calculation. Is your axial length and K reading, measurement errors, uncooperating during the examination, fixation error. During anesthesia, you are not going to get any fixation. And the supine posture which is used for measurements, that itself can create an error. All the instruments are designed for adult eyes. Different biometry and anatomical differences from adults, using adult formulae. And PPC and anterior vitrectomy can affect the effective lens position and target refraction and growing myopic shift. So these are all the errors which can happen. So at birth, the mean axial length is very small. It's only around 17 millimeters, and it grows very rapidly to around 21 millimeters at 1 year of age. There is almost a 4 millimeter change. That is why it is not ideal to place an IOL in the less than 1 year age group in bilateral eyes. At 10 to 15 years, it comes to around the adult size. Similarly, the K reading at birth is around very steep, around 50, and it changes very rapidly in the first 6 months of age. Again, so if you are going to place an IOL, there's a huge chance of error there. So the measurements needed, like we said, to measure the axial length, you can use optical or ultrasound based on the age of the child. Again, in ultrasound, it can be contact or immersion-based methods. So ultrasound biometry we are mostly using in smaller children when we need to measure under anesthesia, where the errors are more likely when the eyeball is less than 20 millimeters long, because a small compression can result in an error of like around 2 to 3 diopters error can come. So when you compare contact versus immersion, so this is an examination and anesthesia which we perform just before the child is going to be operated on, or you can schedule it on an earlier day. There should not be any eyelid speculum, and it should just be just after the induction. And if you are using the contact technique, you should be really sure, because a small compression can result in a huge error. So now we have moved to immersion. We no longer do the contact biometry in small children. The only thing is, sometimes in very small children, the immersion cup doesn't fit very well. So in that situation, rare situation, we use the contact method. So immersion method is definitely much more accurate. In fact, we have a postgraduate thesis going on, and when we compare between the two, the immersion gives better values. So coming to the measurement of keratometry, again you can see that this is a handheld keratometry device which is being used. Again, values are being recorded just before the child is going to be operated on. And with these instruments, it's very easy to get reliable measurements. So those are in children like usually less than 2 or 3 years old. In older children, we can get good optical biometry values if they are able to sit on the IOL Master 700. That is our preference of choice. But here again, after calculating the IOL power, what equation to use right now in our center, we are using the Barrett's 2 formula. Before that, we were using the SRKT formula. I would say these, and in very small eyes, Hoffer Q also gives good results. But how to undercorrect, this is extremely important. Wilson and Trivedi's table is the most accurate table as of now, and you have to look at the target refraction which is given for each month, like 6 to 12 months is around +7 for a unilateral cataract, is around +5 for a bilateral cataract. So you have to enter the target refraction and then look at the IOL power, and that will help to emmetropize the eye as it grows. Otherwise, if you are going to aim for emmetropia, you are looking at a myopic shift of -7 or -8 as the child grows. So the status of the fellow eye also should be taken into consideration. If there is a large degree of anisometropia, that also you should take into consideration. It is always a fine balance between amblyopia and preventing myopic shift. So if you are going to target for only myopic shift, then you may be looking at like +7 or +8 in the immediate post-op, and that can cause amblyopia. So take note of eyes that are very short or very long. Axial length errors are more significant in short eyes, and in a long eye, there may be a posterior staphyloma, so you always look for that. And always, if there is a repeat difference between the two eyes, you have to repeat, because again, that can be a source of error. Also repeat if there is a difference in keratometry between the two eyes, and always look back at your results. And that's when, if you audit your own results, there are cases where we have looked at huge refractive surprise, and we should go back and look at what are the reasons for the above so that we can better our techniques. Thank you.
Thank you, Dr. Sandra. Wonderful talk. Any doubts with regard to biometry in children? We are running short of time. Thank you, Sandra.